Hi, my name is Dr. Amir Faraji. I'm the Director of Functional Neurosurgery here at Houston Methodist Hospital. I'm joined today by Dr. Bill Ondo. He's the Director of the Houston Methodist Neurology Movement Disorders Clinic. And joining us via Zoom is Dr. Mark Richardson, one of my close friends and colleagues. He's at Harvard Medical School. We're going to talk today about leading medicine with comprehensive treatment of movement disorders. At first, we'll have Bill Ondo give us a short talk about his perspectives.
All right, thank you, Amir. So again, I'm Director of Movement Disorders, a neurologist. I was asked initially to talk about all movement disorders at about 20-25 minutes. I thought that a bit ambitious, so pruned it a little bit to tremor in movement disorders because most of the bread and butter movement disorders involve tremor, Parkinson's disease, essential tremor, and dystonia, as we'll see. And these are the movement disorders that tend to be most amenable to surgical interventions. So initially, we're going to talk a little bit about conceptual tremors. So there are a number of different types of conceptual tremors that everyone has, or most people have, at least some of them. A mechanical tremor, we'll talk about just enhanced physiologic tremor, then the sort of tremor in essential tremor, and then cerebellar type tremors. So first, all objects have tremor, okay? If you take a steel rod and you move it and stop it, there will be some slight oscillation. And you can determine frequency based on inertia functions and the properties of the actual object. So for example, a steel rod will have less oscillation than, say, a very expensive graphite golf driver will have, and this is based on properties. So everyone does have this. Usually this is not any sort of a clinical issue, although sometimes the cardioballistic reflex, a slight tremor you get after each heartbeat, can be picked up by medical technology and does get in the way as interference sometimes. So again, everyone has that tremor. Everyone also has physiologic tremor. So physiologic tremor is peripheral, okay? It doesn't involve the central nervous system unless you count alpha motor neurons in the spinal cord. But this is just a reflex. It's the same pathway as a patellar knee jerk, from efferents or afferents going into the spinal cord to the alpha motor neurons, and then you get a response into the muscle. So this takes about 50 microseconds to go from one side to the other, and if you do the math, you end up with about a 10 hertz tremor. And again, everyone, even the world's greatest brain surgeon, has physiologic tremor. A number of things can accentuate this tremor. I mean, anything that increases adrenaline, so again, excitement, fear, pain, exercise, which obviously we never discourage, but certainly exercise worsens tremor, as well as hypoglycemia, sleep deprivation, and a variety of medications and medical conditions like hyperthyroidism classically can all worsen physiologic tremor. Okay, when you get to the pathologic tremors, now you're in the central nervous system, okay? And there are a series of neurons in the brain that are auto-oscillatory. The most prominent of these are in the inferior olive, but in people with essential tremor, for example, you see spontaneously firing rhythmic neurons in a variety of other parts of the brain, especially the thalamus and the cerebellum. And again, we're not going to get into just a little bit of the physiology of essential tremor here, but this is considered pathologic when you see this wider area of CNS involvement that has, again, oscillations that are rhythmic. Now, the last conceptual type of tremor is what's called a feed-forward loop. And this is the sort of tremor that you get in cerebellar disease. So again, when we initiate movement, the initial signals are in the cerebellum. They're not in the primary motor cortex, supplementary motor cortex, whatever. They're in the cerebellum. And in people that have injury to the cerebellum, for example, multiple sclerosis, where you have slowed innervation throughout the cerebellum from demyelination, what happens is the signal to start and stop a movement is delayed. So you want to move your hand down, you want to stop it here, but it's delayed so the hand goes down further. Then you compensate by moving back to the point, but again, it's delayed so it goes too far, and you get these large amplitude cerebellar tremors. So this is, again, conceptually a different type of tremor that we have. So phenomenologically, there's a number of ways you classify tremor, but this is a slide that I think gets at the gist of it. Tremor is first codified into rest or action. So by rest, I mean the muscles are not active. Not that you're sitting down watching TV, but you're not using that particular muscle. An action is any time you're using that muscle. So action can then be segregated into postural tremor, where the muscle is still. So this is the classic stick your hands out, wing beating position. You're not moving, moving, but that's still an action because these muscles are contracting anti-gravity. Then you have the opposite of that, kinetic tremor, where you move. Okay, so again, they're both action tremors. They're subsets of action tremors. And then kinetic tremor can be further subdivided into intention tremor, which is tremor that only exists at the end point. So you're going forward, you have no tremor, and then at the intended point you will shake. Or task-specific tremors, where you only get tremor with certain particular complex motor tasks. And we'll show some examples of these as well. Okay, so again, other ways to classify the physiologic, essential tremor, rest tremor, Parkinson's, dystonic tremor, task-specific tremors. We're not going to get into orthostatic tremor today, but we'll, again, show a video of cerebellar. And then everyone's favorite, functional or psychogenic tremors, if we have time, a couple of videos on that. So, classic essential tremor. This is a very, very common disease. Anytime a disease has to change its criteria every several years, you know it's a difficult thing to define. Essential tremor essentially is action tremor and no other reason for action tremor, okay? So this is a video, okay, the hands almost by definition.
All right, sir, I was wondering if we could hear your voice. Could you just go, ah? Okay, try an E sound.
E.
Okay. Have you turned your head all the way one way? And then...
Okay, so he has, again, a prominent voice tremor. He has head tremor. As an aside here, the way to see subtle head tremors, have them turn left or right, then bring it back. That's when you'll have the head shaking back and forth. He has an immediate hand tremor. Okay, this is an important point with a couple of subsequent videos. So this is an action tremor. This is a postural tremor, okay, but it's an action tremor. He's in the wing beating position. Tremor usually is worse than the wing beating position in everyone. So it doesn't mean if you see worse wing beating position, that is a Holmes tremor or cerebellar outflow tremor or anything like that. And he also has a little bit of leg tremor. So essential tremor, very common. Maybe 1 to 3% of everyone has essential tremor. Men, a little bit more. It does worsen with age. The amplitude worsens, but the frequency gets lower. That doesn't matter much because the disability is associated with worsening amplitude. It is a strongly genetic condition. It's sometimes called familial tremor, but the genetics of this have actually been quite elusive. There's a number of GWAS hits, and there are a couple of linkage genes, but they account for a very, very small percentage of patients. So much of the genetics of essential tremor is still to be determined. It is called essential tremor to differentiate it from Parkinson's, but there are some associated conditions. People with ET have more hearing loss. There is an association with restless leg syndrome, which is another research instance of mine. And then they definitely have worse balance. Most manifest by trying a tandem stance. Tandem stance is a lot worse than tandem gait with these patients. And the rest of these associations are a little less consistent or a little more controversial. Okay, physiology. In 2 slides, physiology and pathology. The increased activity in the brain seems to come predominantly from the cerebellum in essential tremor. Interestingly enough, if you put one arm up and one arm is shaking, the bilateral cerebellar will be activated in essential tremor. In contrast to someone without essential tremor, where obviously you only have unilateral activation of the cerebellum for a volitional mimicking of essential tremor. Pathology. Well, it is a heterogeneous condition. There's no doubt that what we call essential tremor is more than one disease, okay? There are some patients that have Lewy bodies like Parkinson's. There is evidence of cerebellar degeneration, and there's also evidence of abnormal neuronal connections from the inferior olive going into the cerebellum, and that's actually maybe the most robust finding. Obviously, this is nothing that you're going to pick up even on a routine autopsy, and certainly there are no clinical biomarkers for essential tremor, no test that you can do. In 5 slides, just go over a couple of treatments. Everyone's interested in ethanol, beta blockers, and primidone, and will allude to surgery. Alcohol improves essential tremor in the majority of patients. It's very quick. It doesn't take much. It's the equivalent of 1 drink, typically 10 to 15 minutes, and you get a few hours benefit, followed often by a rebound exacerbation. So is this a viable treatment for essential tremor? Well, I guess that's debatable. I certainly don't have a problem with patients taking this on a PRN basis myself. Beta blockers, that's the key take-home point with beta blockers for essential tremor, is that the non-cardiac selective beta blockers are superior. This basically results in propranolol and nadolol are the two best beta blockers. They definitely work better than, say, atenolol, okay, for essential tremor. They are dose dependent, and again, this is thought to be mostly a peripheral mechanism, but there's some evidence of central mechanism of action for beta blockers as well. And then primidone is the medicine most people that don't do this are less familiar with, a very old drug, a little bit more hit or miss with essential tremor. It works very well for classic essential tremor, less well if they have dystonia and jerky components and so forth. But again, this is a medicine that we very frequently use. As a movement disorder specialist, I will inject botulinum toxin in just about anything. Tremor is certainly no exception to this, and the botulinum toxin works by weakening muscle. And the idea is to target the correct muscles for essential tremor. Can be exquisitely good for head tremor, for jaw tremor. It can be very good for hand tremor if it's mostly a simple oscillation around the wrist, but when you start to get elbow, finger involvement, the shots generally are not satisfactory. And then to be discussed in more detail in the next lecture, there are a number of surgical options, basically breaking down to deep brain stimulation versus various lesioning technologies. Okay, so let's segue a little bit into Parkinson's disease. Rest tremor, of course, is the classic feature of Parkinson's disease, but this can be a little bit tricky sometimes. There are a certain number of patients with essential tremor that do have rest tremor, and as I said, there is some Parkinson pathology in some patients that are diagnosed with essential tremor. So a couple of subtle but important points if you're really trying to sort this out. So you look at this woman, her hand was tremoring while at rest. As soon as she puts her hand up to action, there's even a worse tremor. And again, it's an immediate tremor. Again, so very high amplitude, very severe. She is DBS deficient at this point. Finger to nose is the purest way to see an action tremor, okay? So there's no rest component of this at all. But at the beginning, she did seem to have a rest tremor, okay? And this is one of those patients that had 50 years of ET and developed a pseudo rest tremor, because if you look now, and I know that's a very brief episode, but if you look while she's walking, there is no tremor, okay? The purest form of rest tremor is while walking. People that have apparent rest tremor while sitting, this is sometimes again called a pseudo rest tremor, and it's a very, very common feature in long-standing essential tremor. Often people in their 70s, 80s, 90s, they often develop this pseudo rest tremor. Okay, so Parkinson's disease is defined clinically, rigidity bradykinesia tremor. I spend very little of my time dealing with this, again, extraneous to this talk, but there's a whole slew of psychiatric, sleep issues, autonomic issues, and a variety of miscellaneous things that we spend most of our time treating in Parkinson's disease. So again, classic rest tremor, but there are exceptions in this too, clinically, as you'll see in just a minute. Parkinson's disease is a very complex disease, also heterogeneous. There are 15 genes now that cause Parkinson's disease. They still account for about 7% of all cases, but it's consistent with all of the Parkinson diagnosis is a deficiency in dopamine. It's not the first thing that happens, okay? In fact, it may be 5-10 years into the disease before there's a meaningful loss of dopaminergic cells, but you really don't get Parkinsonism until you lose dopaminergic cells. Okay, so let's look at a little bit of a tricky case here. So she has a very nice rest tremor, okay, granted sitting down, but take my word for it, she has tremor when she's standing up, the same. And that, you know, she looks Parkinsonian. So initially no tremor with action, but you'll see this gradual crescendo. And this has gone by many names over the years: crescendo tremor, reemergent tremor, tremor of postural repose, it's been called poetically. When you go to move it, so again, now you really have action, the tremor will stop, but after a while it'll restart. So technically, you know, this is an action tremor, okay? She's sitting there, but it obviously is the same tremor. It's the same frequency, it's the same phenomenology. It's a rest tremor because if you're still long enough, the brain starts to think that's a rest tremor, okay? Again, not going to get into this at all, but we have 21 FDA-approved medicines for Parkinson's disease now. Most of those are dopaminergic, but we occasionally use non-dopaminergic, and then surgeries to be discussed in greater detail later. All right, so let's talk about a couple of other miscellaneous movement disorders that have tremor as a component of it. Dystonia basically means patterned involuntary movements, okay? And you can get dystonia any part of the body. The neck is the most common that presents to a physician. Writer's cramp is probably the most common dystonia out there, okay? It just often doesn't present to a physician. But again, there's many genes that cause dystonia. It's a heterogeneous condition as well. But many patients with dystonia will have tremor as part of it. So again, this is a woman with fairly classic left torticollis. So torticollis technically means rotation to the left, but her head is jerking. I mean, there's no way you couldn't call that a tremor, okay? Now, these tremors for dystonia are often very position dependent, and if she really goes to the extreme position, when now you really put the antagonistic muscles at rest, then the tremor will often stop. Okay, so again, this is a very, very common phenomenon. In fact, about 30% of people with cervical dystonia will have tremor. If what I teach fellows is if they don't have hand tremor and they have head tremor, it's cervical dystonia until proven otherwise. Okay, so the vast majority of these people have dystonia, but there is no biomarker. Okay, so this is based on the clinical expertise of your local movement disorder specialist only. Okay, task-specific tremors, these are some of the most interesting ones. These have some features of dystonia, some features of essential tremor. The little physiology that's been done on these is more consistent with essential tremor in that you get cerebellar activity, so forth. The most common is writing, but you can get task-specific tremors with just about any task that someone does repetitively. So here's a woman with essentially no postural tremor, okay? Maybe a very, very slight kinetic tremor, which many people would have the same sort of tremor. But otherwise, really not much there. As soon as she goes to write, though, very dramatic, task-specific writing tremor. Okay. She has tremor in no other activity. Now, often sometimes these will stay task-specific their whole lives. Other times over the years, they will become less task-specific, and eventually, in some patients, they will develop postural tremor. So there's always been some debate. Is this a spectrum, or is this really a different disease? I am kind of in the splitter category here, and I do think this is a separate disease. Just to make a point, you can have tremor in other parts of the body. This is a woman that has a task-specific drinking tremor, which is not very uncommon at all. So she really has no jaw tremor there, doing a variety of things. But as soon as she goes to drink, she will have a very dramatic chin tremor. And again, I have about a dozen of patients just like this. So again, you can't get task-specific tremors with other activities other than the hands, okay? And then the last couple of tremors, cerebellar outflow tremor. Again, this is from a trauma, very common in trauma, typically a head-on torque injury where you injure the cerebellar outflow tracts, and these are very, very difficult to manage. So here's someone, I think this was a head trauma case, and you can see the very large amplitude, very proximal, often somewhat irregular. There's other features. Sometimes they have some even Belismus type features as well superimposed on the tremor. Very, very difficult, certainly almost impossible to manage pharmacologically, and somewhat more difficult to manage surgically as well. But again, these sort of cerebellar tremors. And then the last couple slides, my least favorite is functional or psychogenic tremors. The tendency is to call these functional instead of psychogenic or conversion disorders these days. Typically young onset, women more common than men. There's a number of clues. I mean, there may or may not be an obvious stressor, but you do see when they do the tremor, there's a number of clues here. Variable frequency, the directions change quite a bit. They can be very, very suggestible. So this is what, about a 4 hertz, 3 to 4 hertz tremor up and down. You're always going to get the tremor in the easiest way to shake. So now forward, it's a flexion extension tremor, much higher frequency. Then it changes planes entirely again when she moves one more time. So in the last one, as far as another psychogenic tremor, distractibility, some of the things that we do to elicit tremor would be to again make them do other volitional movements. It's very hard to have two different frequencies going on. So you have tremor in the right hand here. When we have her do something else, the tremor will stop. Okay, if it gets more complicated, so we have them do this certain pattern, you get the tremor will stop for a longer period of time. You can entrain it from a frequency standpoint as well. And again, it's the company it keeps to make this diagnosis of functional or psychogenic tremor. There may be obvious psychopathology, there may not be. Okay, so in conclusion, again, tremor disorders run a large gamut of different movement disorders. They do have different phenomenology, sometimes obvious, sometimes subtle, and they all have treatments to some extent, but it's all based on the correct diagnosis to start with. Thanks.
Thanks, Dr. Ando. So I'm going to pivot a little bit and talk about that subset of patients that funnel down to the surgical pathway. And I'm going to explain how that's done here at Houston Methodist in particular, before getting to Dr. Richardson's talk. So again, we're going to focus this talk on deep brain stimulation here at Houston Methodist. What I'd like to start with here on the slides is the history of deep brain stimulation. In particular, in the 1930s to 1940s, neurosurgeons were understanding how the brain works, how anatomic mapping of the brain, the cortex and deep structures of the brain are involved in function. Later, to access deeper areas of the brain, neurosurgeons developed minimally invasive stereotactic methods to deliver and tap into these deep areas of the brain. Later, such as in the 1960s, neurostimulators came into advent after the cardiac pacemaker was developed in 1960. Levodopa was introduced as the dopamine replacement medicine that we now know today in 1967. And then there was a lull of about 10 years or so as surgical innovation paused until we understood that levodopa has side effects with long-term use. So later in the 1980s, especially 1987, a French researcher, Ben Abid, developed deep brain stimulation in particular to treat essential tremor and Parkinson's disease. And then targets were elucidated over the next 5 or 10 years to the current targets that we use today. The first commercially developed deep brain stimulator was developed in 1997, and it was FDA approved shortly thereafter. The typical indications for deep brain stimulation involve Parkinson's disease, essential tremor, and dystonia, similar to what Dr. Ando mentioned, but also other non-movement disorder diseases such as OCD, epilepsy, etc. Many of these patients in this group will develop medically resistant symptoms that impact their quality of life and should therefore be considered for surgical intervention. To briefly sum up Dr. Ando's slide in a single slide here, for Parkinson's disease, what you can see is Parkinson's is a constellation of motor and non-motor symptoms. And in particular, motor symptoms onset early in the disease process that can be bradykinesia, rigidity, or even tremor later on in the disease process. If you get later into Parkinson's disease, you can have the onset of serious issues such as dysphagia or even falls. This coincides with the progression of non-motor symptoms as well, such as hallucination sometimes as well. Levodopa is the mainstay treatment for Parkinson's disease, and this was developed in 1967 and then advanced to the current day. Early in the disease process, you can see that as levodopa is dosed, here, what you can see is there's fluctuations in the level of drug in your body. And the goal is to keep that dose well controlled in an area where you're not having off symptoms of bradykinesia or tremor, but also not having side effects from the medicine themselves in terms of a dyskinesia or rhythm type movement. Later in the disease process, as you dose more frequently or with higher doses, you can get significant fluctuations. And you can have patients that have tremor, but also have that dyskinetic type movement. And the goal of DBS is to even out this process so that patients are well controlled in that on period. There are some symptoms that are helped by DBS. So in particular, as I said, we can increase that on time. We can decrease the bradykinesias and rigidity of patients. We may be able to reduce medication doses and even up to 25 or 30% of that dose. We can improve dyskinesias. We can also effectively treat tremor. But non-motor symptoms such as gait or balance problems or even cognitive problems or depression, unless it's situational, just related to having symptoms of Parkinson's, those are not necessarily helped by deep brain stimulation. So in my mind, a traditional candidate for DBS demonstrates a response to levodopa replacement therapy, has had some on-off fluctuation that we could help with DBS. They've had dyskinesia, some resting tremor, the absence of a dementia or even severe depression, a normal MRI, and also they must be able to undergo the procedure with anesthesia and medical clearance. DBS is not a new therapy. It's been studied for many, many years. As I said in the initial slide, it was developed more than 30 years ago. And through the 2000s, with several high-profile clinical trials, we've elucidated that deep brain stimulation gives patients almost 5 hours of on-time extra each day per average. We can decrease medication doses roughly 25%. We can reduce tremor up to 75% on average, and we can therefore improve quality of life. But it's not only that. This is a study looking at patients that had DBS earlier in the disease course, of having the disease only for 7 years instead of 10 or 12 years. And what we found in this study also is that patients had improvement in quality of life, improvement in motor disability, and DBS was superior to best medical treatment. There were 2 targets approved for deep brain stimulation of Parkinson's in 2002, in fact, just so you know, globus pallidus interna and the subthalamic nucleus as well. And the goal of a combined approach with movement disorder neurologists and the neurosurgery team is to really look and evaluate which of these targets are best for these patients. Shifting gears again to essential tremor, as Dr. Ando mentioned, the mainstay target for this is in the thalamus itself, and this was approved as the initial DBS target in 1997, in fact. And this improves tremor by roughly 80%, is thought, as well as handwriting by roughly 70%. But it may not eliminate tremor completely, and sometimes tremors worsen with age despite deep brain stimulation. Vocal and head tremors are difficult to eliminate completely, and then some DBS settings, depending on placement, may cause dysarthria or even disequilibrium of patients and some balance issues. But this is the goal, to take a tremor, such as when drawing this spiral, and reduce it down to something that's intelligible, help you write your name on a checkbook, or even help you drink a glass of water. The last indication I want to discuss briefly is primary dystonia. This was given a humanitarian device exemption by the FDA in 2003. And the typical target for this is the globus pallidus, but also perhaps the subthalamic nucleus in some cases. And the effects of this treatment are not necessarily immediate, and symptoms may still progress despite DBS. This is not as good for secondary generalized dystonia, and it may not improve issues such as with speech or swallowing. And ultimately, younger patients are experience better outcomes than older patients with this treatment. Here at Houston Methodist, we have a strong experience in deep brain stimulation. This is a single surgeon series done here between 2002 and 2010, where we've done over almost 730 patients with deep brain stimulation. And the vast majority of these had Parkinson's disease, essential tremor, or dystonia, as I talked about. And the complication rates of these procedures are actually quite low. So from this series, what we've discovered is that the risk of a bleed is about 0.5 to 1%. The risk of an infarction or a stroke is about 1 to 2%. A wound infection is about 1 to 2%. And there's also a 1 to 2% of lead misplacement or lead migration, which is seen in this study. So overall, this is a very low-risk procedure when done correctly. As I mentioned, it takes more than a neurosurgeon to perform DBS. Ultimately, the path starts with a movement disorder neurologist, as well as a good medical evaluation. Neuropsychological testing is important to understand cognitive effects of your disease before and after surgery. But also physical therapy plays a role, because some patients that have balance disorders, maybe we can improve or even worsen them with this treatment. So we discuss the patient's individual case in a multidisciplinary conference and come up with an individualized treatment plan, and then enact that plan with the patients as well. Here at Houston Methodist, we perform DBS in 2 distinct stages. The first stage deals with the brain portion, and the second stage deals with the battery portion in the chest pocket. There are 2 different ways of performing the stage 1 or brain portion of the surgery. We can perform it awake with the patient interacting and performing tasks and looking for targeting side effects or even a benefit in the operating room itself. And here, when we do those surgeries at Houston Methodist, we use robotic assistance for accuracy benefit, which I'll mention in a little bit. But we can also perform the surgery asleep, either with robotic assistance again, or even in the MRI scanner, to visualize the path of the electrode in real time and understand what functional target we can hit in real time. The second stage is an outpatient procedure that's done under general anesthesia to tunnel wires down the neck from the DBS lead, but also to the battery pack in the chest. This is the general workflow for an awake procedure, such as with Parkinson's disease patients, where we would place a guidance frame on the head before surgery with some sedation. And that allows us to make a 3-dimensional map that we overlay with the preoperative MRI scan that we can register to the stereotactic robot to complete our surgery. We then start our surgery with the patient again sedated, perform the incisions, make the small craniotomy, the small openings in the skull of the patient to allow us to insert the microelectrodes for brain recording. The patient is awake during this part of the surgery. We get a baseline exam. We insert the brain electrode recording. We perform the brain recordings, and we evaluate the effects of the individual tracks. Ultimately, we do place the lead and test the lead in the operating room and look for benefit clinically. Once we're satisfied with the good placement of the electrode, we close the incisions and we get a postoperative CT scan to verify placement. I want to show you some pictures and images of surgery so you have an idea of what to expect. So in particular, this is what the Lexel frame looks like, the middle picture. So it's a device that affixes with 2 pins in the front and 2 pins in the back to the head. And that's what we use to make a stereotactic or 3-dimensional map of the brain. We use a surgical robot, which is shown at the left. And the surgical robot has an arm, and I work with this arm in position to guide us to the correct target with the accuracy introduced by the robot itself. And ultimately, the DBS device has a brain incision, 2 on either side, if it's a bilateral surgery, with a wire that goes down the neck to a battery pack in the chest. The surgical robot, again, acts via skin or the frame, skin markers or the frame itself, to create a 3-dimensional map and could give high accuracy and precision for biopsies, electrode implantation such as DBS, endoscopic procedures or catheter placement procedures. It can reduce operating room time, increase precision of these procedures, and also simplify these procedures because you've developed a standardized workflow. Myself and Dr. Richardson, who you'll hear from in a few minutes, developed a method for registering this robot and performing awake deep brain stimulation in patients. And what we showed is a learning curve in the initial patients, but ultimately what we could achieve is high accuracy, less than a millimeter, with experienced surgeons. And this rivals, if not better, to the traditional frame-based approaches. This shows how we register the frame to the robot. Basically, we take a pointer attached to the robot and place it in the divot of these pins. With these divots, we can create a 3-dimensional map, therefore, of the brain. The patient is hooked to the robot with their head immobilized as they're laying on the operative bed, and we can place the leads to the correct targets with good accuracy, again, sub-millimeter accuracy. During surgery, as I said, we can perform awake testing. This is the gold standard in some respects because we can evaluate the response to stimulation. Also, we can evaluate and minimize any off-target side effects. And so many patients with tremor, we can test their tremor in their operating room. We can test their bradykiniesias or cogwheeling. On the morning of surgery, they don't take their medicines for their movement disorder, so we try to have these symptoms be brought out in the operating room so that we can reverse or improve some of them with the DBS itself. When we perform brain recordings with microelectrodes, what we do is we pass these tiny, thin electrodes through the brain tissue itself, and we can look at different points of the brain and evaluate brain activity. And depending on the track with the most activity and also the least side effect and most clinical benefit, we can ensure that we have good placement of the electrodes by the time you even leave the operating room. As I said, we can perform this surgery with you as the patient completely asleep. And so what that means is from A to Z, placing the frame, placing you and registering to the robot, performing the incisions and the creation of the bone openings, as well as placing the leads down to their right targets, that can all be done with the patient asleep for ones that are anxious or that have an indication that they can't undergo an awake surgery. And then we do obtain a postoperative CT scan in these patients as well to verify placement and accuracy. This shows the new advent of advanced imaging that we can use for evaluating deep brain stimulation leads. So in particular, this is of the subthalamic nucleus, and the DBS leads are at their functional targets in the subthalamic nucleus. We can resolve it, we can spin, we can create 3D images of this and really evaluate that we were in the right spot. But beyond just having a pretty picture, this also can inform the neurologist that's programming the device after surgery how to best steer an electric current, for instance, how to best reduce side effects from programming itself. So this is a real strength, having advanced imaging and deep brain stimulation surgery as well that we offer here at this hospital. Finally, the last approach I want to mention is with the patient asleep completely, but doing this in the MRI scanner. So you undergo general anesthesia. You have a compatible head holder place that goes in the MRI scan. We get an MRI scan for intraoperative planning while you're asleep. We create the small bone openings of the head. We place the DBS leads on each side. We verify that the leads are in the right spot after securing them, and then we wake you up and you are preserved in the hospital for the same 1-day period overnight typically. This shows the tower that we use to dial in the coordinates to project the DBS lead to its target. And it has a series of coordinates that you can manipulate to get us to the correct target. This is called the clear point system. And it's been shown in similar research in the past couple of years to have similar efficacy to traditional awake DBS. And this is again for patients that can't undergo an awake surgery. This slide shows the typical setup, including the grid placement on the surface of the skull that allows us to pick the proper entry points and again dial in the coordinates with the clear point tower to hit the target accurately. So the difference between traditional awake DBS and a sleep DBS with or without the robot is that awake DBS gives the advantage of being the gold standard. You can evaluate the functional targets by verification of the clinical exam. You have the opportunity to use microelectrode recording and intraoperative testing to verify. But it does require cooperation of an awake patient. With a sleep surgery, you have the advantage of an asleep situation, sleep conditions, and that you use anatomy and high resolution imaging alone to place the DBS lead to its accurate target. The disadvantage is that it relies only on anatomy, so you can't actually verify until after the patient wakes up and is programmed. But it turns out the results of both of these surgeries are similar, and each patient should have a detailed discussion with the surgical team to determine which option will be best for them. And most importantly, perhaps this patient preference is also considered depending on what the patient would like. Surgery is performed again in 2 stages. Stage 1, you typically stay 1 night in the hospital. Stage 2, with general anesthesia, is an outpatient surgery. Surgery is performed through typically 3 or 4 small incisions on the head and then the chest pocket. Recovery is about 2 to 4 weeks. You follow up with the neurosurgeon, myself, and about 2 weeks or so for wound inspection and staple removal after the stage 2 surgery. And then you also see the movement disorder neurologist, such as Dr. Ando, where you would visit with them every 2 to 4 weeks after the stage 2 surgery, perhaps every month for the first couple months after that, and then visits are spaced out afterwards. Medications can be adjusted during that time, and DBS is performed in a non-invasive way through just wireless transmission to the battery pack itself. The improvement is gradual, and it may take several months to achieve maximal or optimal results. There are 3 device manufacturers for deep brain stimulators: Medtronic, Abbott, and Boston Scientific. And I would say that the current device manufacturers are all developing improved rechargeable devices, directional brain leads, responsive sensing therapeutic devices, which I want to let Dr. Richardson talk about more in depth because he's going to discuss really the strength of these new technologies in DBS surgery. So overall, I would say that DBS for movement disorders such as Parkinson's disease, essential tremor, or dystonia have been heavily studied over the past 30+ years and have been demonstrated to improve symptoms and quality of life in patients. We have a multidisciplinary team at Houston Methodist to determine whether a patient's a candidate, what surgical target may be addressed, the appropriateness of device manufacturers, and what your individual condition is to treat your movement disorder. We are the only surgical center in the region to utilize advanced robotics, intraoperative MRI, other technologies and techniques to place these electrodes in a safe and accurate way with patients awake and or asleep during parts of their surgery. While risk exists with any type of surgery, I promise we make every attempt to minimize these risks, and the complication rates of DBS are very low, though they do exist. So with that, I'll turn it over to Dr. Richardson.
Thank you, Dr. Faraji. It's a great talk by both you and Dr. Ando. I appreciate the opportunity to talk for a few minutes about this theme of personalizing DBS therapy, which will continue some of the concepts that you were just mentioning. So here's a general overview of movement disorder surgery. This falls into 2 areas, one that's not experimental, which is deep brain stimulation. The other is experimental, and there are a couple gene therapy trials underway in Parkinson's disease that utilize the same delivery system that you described for implanting precisely a DBS lead in the brain using real-time MRI. So we can also use that same method, ClearPoint method, to deliver a cannula for drug infusion, for instance, for gene therapy for Parkinson's disease. And we have other studies the field does coming down the line, for instance, for Huntington's disease. But focusing on DBS, As you mentioned, there are two ways to do this, awake and asleep. And now it's been over a decade that we've been doing DBS asleep in the MRI with outcomes that are essentially equivalent to what would be obtained with regular awake recordings. And the next phase for DBS is really this idea of adaptive DBS, which is using signals that can be recorded from new versions of DBS leads with sensing or recording ability. And these systems will be able to evolve to use information in real time to change the type of stimulation that's delivered. So by adaptive DBS, we mean the systems will be able to automatically change their stimulation parameters in response to recorded brain activity. And so this is something that the field has been waiting for a long time, and it's partially here because we do have one device that we can implant where we can record brain signals, and the neurologist, Dr. Ando, and others can use that information to inform changes that they might make in the stimulation parameters. So this is an important concept to hit on, which is the fact that DBS is an underutilized therapy. So for instance, in Parkinson's disease, it's estimated that just 10% of people who would benefit from DBS therapy actually get it. And the reasons for this are multifactorial. Certainly, nervousness about surgery, undergoing brain surgery is one of them. That is understandable. And fear probably about being awake is a large component of that. I do think this idea of personalizing DBS is something that hopefully will catch on both with referring providers and patients themselves, because the recording of, or the promise of recording from the brain with these devices is really one of delivering personalized medicine to patients. And so for the most part, over the history of DBS, there, with some subtleties, is an approach to implant the lead and turn it on and to essentially try the same algorithm for everyone, which tends to work very well, as you pointed out. I mean, DBS is the gold standard for Parkinson's disease when motor fluctuations are present. It does better than medical management. But we hope that we can do even better for patients, and that this idea of using information recorded from patients' brains can really personalize that experience. And overall, we hope that this has an outcome of optimizing and reducing the amount of medications, for instance, that a patient has to take. For this promise to be realized, it's going to require a few things. One is understanding functional targeting, which is something that Dr. Faraji just introduced us to. We have to also keep improving our understanding of the neurophysiology of disease states and, of course, of the neurophysiological responses to stimulation. So how do we do this? In DBS surgery, as just mentioned, the goal is to place the electrodes in the functional target. So in the part of an anatomic target that we know to be involved in the generation of symptoms in the circuit that's affected, for instance, by Parkinson's disease or by essential tremor. Dr. Ando did a great job of giving us an overview of some of those circuits. This is a picture showing the reconstruction of two DBS leads in the subthalamic nucleus, which is the orange nucleus here. And the sensory motor territory of that nucleus is the dorsolateral STN. And so these leads appear to be well positioned, but how do we know that's the right functional target in terms of stimulating there and correcting the symptoms that we would expect to be corrected in Parkinson's disease, for instance? And this is one way. So this is a figure from a study. There have been others like this that, based on the position of DBS leads on postoperative MRI, have evaluated the effect of moving leads that were perceived to be off target based on the anatomy. So those would be the black circles. And if the target of the STN is roughly here, you draw a line in front of this structure, here's the red nucleus, and you get over to the STN at a certain stereotactic level in the brain that can be defined on our software platforms that we use for targeting. And one moves the electrodes by either taking out the one that's was misplaced or putting another one down right beside it. These patients will get significant benefit with movements of the lead that can be as small as 2 millimeters. So for instance, if a lead is clearly outside the STN and it's moved into the STN, that can make a big difference, because when the lead is in part of a pathway that's going to cause a side effect before it can cause any efficacy, that's a big problem, and the DBS is just not going to function as expected. So over more than a decade of evaluating where leads end up on postoperative imaging and correlating that to intraoperative physiology and the traditional way of doing DBS and recording brain physiology and testing symptoms intraoperatively with stimulation, there is consensus on the anatomic targeting based on MRI for the two main targets in Parkinson's disease, GPI and the STN, as well as for the thalamic target in essential tremor, even though you can't see that one as well. Typically with indirect targeting, one can do a really nice job with that. So in my own practice, I still like to do all the essential tremor cases awake, but certainly have done some asleep, because as Dr. Faraji mentioned, there are just some patients who will not be interested in DBS surgery if they have to be awake. So we'd rather take a shot on doing it with imaging alone in the case of essential tremor, if that's the only way to move someone to DBS, because the quality of life improvements can be so large. So now moving back to the idea of adaptive DBS. So let's assume that we've got the electrode in as optimal a place as we can get it. Well, then what can we do to make the device work better over time? And one of the things that we can hopefully do is to use information that can be recorded from some of these new devices. So we're at a stage now where we have these sensing-enabled devices that are being implanted. They're being implanted at Methodist and other places around the country now. And the person doing the programming can read information that's recorded and can make a manual adjustment. The next step will be when the device makes some of these adjustments on its own. And then ultimately, we think the technology will progress to intelligent adaptive DBS or AI DBS, where the devices can, in fact, learn over time how to make adjustments. And I really do think that we might be able to integrate this sort of technology with recommendations based on the brain physiology for potential medication changes. So this would kind of be a holy grail situation in terms of what AI DBS might do for patients. But we're certainly started along this pathway. And I think the ability to use this device across different movement disorders will really help us to understand the best way to use this type of information. This is the only FDA-approved device now for movement disorders that has this sensing ability. It does not have the closed loop or adaptive function turned on, but still the person doing the programming can evaluate signals recorded from the brain and use that to make decisions about how to stimulate. Here's an example of that, of what this looks like on the device program, the tablet that one can use to program the device and also to read brain signals now. And this just is a picture of where stimulation and recording is happening. And you can see there are different channels, and one can look for peaks in certain type of activity in the brain, neural activity. And we conceptually organize these different types of activity into frequency bands. Some of these frequency bands have been associated with specific symptoms in Parkinson's disease, like tremor or bradykinesia, rigidity. And beta activity is one that's been highly associated with bradykinesia, or slowness of movement. So the idea here would be to detect a peak in beta activity, to identify where that is in the subthalamic nucleus based on which recording electrodes were used to detect that signal and then potentially drive our stimulation in that area to optimize symptom reduction. So that's the way we're thinking about using this information. Now, here's another example that just shows a particular beta peak. And if a patient who's implanted with this type of device comes in for their programming visits and one's looking at the physiology over time, there can be a depiction of how this changes and whether or not this correlates to symptom reduction, which I think will be very helpful across the field. It's the early days. Once we get a better idea of how to use this information, I think this is very powerful for patients because they have a record of their own brain activity chronically recorded. And we've seen, for instance, with our use of closed loop simulation in epilepsy, this is a very powerful tool, and it's also a great way to connect with patients. I think the patients have a different perspective when they know that the physicians are using their brain information in ongoing fashion to help optimize the therapy that the DBS is delivering. And I'll just mention that there's a clinical trial that's underway. So this is a real idea, a real thing that's happening. And I think this ultimately will be successful, and we'll see some of these tools being unlocked on the devices. The devices are capable of doing closed loop DBS, but not yet FDA approved. Okay, what's another way to personalize DBS, aside from using the physiology of the brain recording? Imaging. And there are different types of imaging techniques that we can use to estimate visualizations of the pathways in the brain that connect different parts of the circuit that are affected in Parkinson's disease or other movement disorders, and that we might modulate with DBS simulation, depending on where we put the lead. And we can do that in two ways. We can get a readout from someone's own brain, just a single patient estimation. But then we can also compare that to finer resolution connectome. So connectome is what we call kind of global picture of the connectivity of different areas of the brain to each other as visualized with these tractography methods in MRI. And the resolution of these methods are increased when you can combine data from a lot of patients. So that's called a normative connectome. And this information can be instructive in terms of estimating lead location in terms of ability to affect different brain circuits in a different way than getting a scan from just one patient. So this is being used increasingly to analyze data that's already been collected to try to fine-tune targets, and also to try to match the structural connectivity and functional connectivity as defined by MRI, functional MRI studies, with the type of functional connectivity measures that we can collect in the operating room and with the neurophysiological readouts from the target. And so, for instance, using these types of methods, we've been able to get a better sense of the finer detail of variations in physiological activity, oscillatory activity, for instance, in beta and alpha bands in the subthalamic nucleus. And these match our conceptualization of the topography or the organization of information flow through these brain regions, which have, and this understanding has a very big impact on our ability to, for instance, optimize control of motor symptoms without affecting non-motor symptoms. That's the goal. And here's just an example from OCD, obsessive compulsive disorder, where visualizing these white matter pathways, the connections between these brain regions, is becoming increasingly important. And it's very clear that stimulation locations within or outside of these pathways have different effects on symptom relief. Movement disorders, it's probably a little different in terms of the target and being white matter or gray matter. But we're still figuring it out. And I think the technology continues to improve to allow us to do that. So a summary of this kind of brief state-of-the-art overview is that technological advances are allowing DBS to become more and more precise. I think this is happening both in awake cases in the operating room and in MRI, real-time MRI cases with patients asleep. This increased precision, we hope, will allow for increased personalization as we understand these functional targets at higher resolution. And the ability to obtain chronic brain recordings really does herald a new era in personalized medicine, where we can now focus a lot more on the individual patient variabilities, and use the patient's own brain data to inform the best way to program their device. So that's it. Thank you again for the opportunity to participate today.
Thanks, Dr. Richardson. I really appreciate that talk. I mean, it turns out that we've been learning about the brain for 80 or 90 years to get to a point to develop a technology like deep brain stimulation. And now deep brain stimulation is helping us learn even more about the brain than we knew already, at the same time that it's helping patients. So that's wonderful. I'm going to turn it over to anybody if you have any questions or want to discuss anything more about this.
I'll make a comment on that point, Dr. Faraji, which is that it used to be, even when I started practice, we might make an introduction to the patient. They would say, well, how does this work? And we might say, well, we're not sure exactly. We have a couple of clues to this. And we've inferred how it works from lesioning, which is what we used to do to the brain before we figured out how to put electrodes in and not make permanent lesions. And now things are a little different, as you mentioned, and that's a result of work that can be done in the operating room with intraoperative research. And we know that some mechanisms of DBS can be measured by looking at different changes in patterns of brain activity that are induced by stimulation. So for instance, we've been able to identify pathologic oscillations and then to see how those are canceled out with DBS. And this has really improved our understanding of, I think, network physiology. And so we do have a sense of how these devices work now. We don't have it completely figured out. But hopefully that's also, as this becomes less mysterious to us, will also become less mysterious to patients.
And most of this newer technology is based largely on Parkinson's physiology. Is there anything analogous to this in essential tremor?
Yes, essential tremor, both in the thalamus and at the cortical level, well, actually, there are a couple ways to think about that. The tremor frequency can be detected at the local field potential level, like it can at the single neuron level in terms of tremor frequency. For essential tremor, one of the ways that closed loop DBS is evolving is that because of the intention nature of the tremor, that one could put a cortical strip electrode over the primary motor cortex. And so when the patient makes a movement, they want to go drink a cup of coffee. And so they're sitting still, they don't have a tremor. Without the device on, they go to pick up their cup, and it's like this. But if the device detects that they're going to move and then turns stimulation on, then that can be helpful. It doesn't have to be on all the time, it can save battery life. I really enjoyed your slides about the cerebellar physiology, and I think this is, there's still a lot of potential to understand better the cerebellar physiology. As neurosurgeons, we're not in the cerebellum recording much. It's hard to get to for the point of recording like we typically do in DBS. But I do think that there's potential there too. And in dystonia, I think the best known biomarker that might correspond to the beta biomarker of bradykinesia is a theta biomarker that seems to correspond to dystonia, to dystonic symptoms. And why that is and why they would be different is not clear. But one thing I think the technology is showing us is that maybe able to parse out different symptoms, even within the same patient, based on the physiological readout. Our devices are probably too crude now to ultimately take advantage of that. But in the future, as the technology continues to evolve, hopefully that will change.
Yes, and to be clear, these different bands, alpha, beta, theta, are predominant frequencies after Fourier analysis for these field potentials. So it's based on just how fast. And in Parkinson's disease, for example, when they take medicines, levodopa, you'll dramatically change these frequencies, and DBS can mimic that in many cases.
Well, I wanted to thank both Dr. Ondo and Dr. Richardson for being with us today, and I really appreciate the discussion and allowing us to explain to you about our approach to deal with and treat movement disorders here at Houston Methodist Hospital. Thank you, Dr. Ondo. Thanks, Dr. Richardson.
Thank you.